We're about 1 minute from the start of our program. Hello, this is Dr. Brian McDonough, and welcome to our HSX University program focusing on PA Navigate, as well as communication and outreach to our communities. We have a distinguished panel with us. I also been told that we have one of our largest audiences ever, which is wonderful, and I'm not surprised because of the topic. It's such an important one. And I thank everybody for joining us. We hope to provide a lot of information, but in addition to that, give you an opportunity as we move forward to ask questions through the chat that we'll also try to address. We have about an hour, so rather than sit and take it all up introducing things, I want to introduce each of our experts and then get right into the conversation. I first want to introduce Bill Maroon. He is the Chief Operating Officer, Pathways to Housing Pennsylvania. Bill, you could say a few words about yourself and why this is such an important presentation.
I'm Bill Maroon, Chief Operating Officer, Pathways. We have about 500 people who live in their own apartments across the city who were once formerly homeless. We have about another 100 people that we're going to be trying to house this year. And I'm very excited for what HSX has already done for us, but to add this level of information for all nonprofits, it will be great for us. As a nonprofit, we continue to try to struggle to use data better and be data driven. And I just think this will be another level of information that will help us keep people housed and house more people.
Thanks, Bill. Josh Claris is Executive Director of North 10 Philadelphia. Josh?
Yeah, hi everybody, good afternoon. I'm Josh Claris. I am the Executive Director of North 10 Philadelphia. And North 10 is a place-based organization focused on the Hunting Park, East Tioga neighborhood in North Philadelphia specifically. And we exist to improve life outcomes of the residents of that neighborhood, of which there are, give or take, about 6,500 Philadelphians living there. And any opportunity that we can to improve health outcomes is what we're about. So excited to participate in this conversation.
Thanks, Josh. Steve Carson is Senior Vice President for Population Health, Temple Health. Steve, you could say a few brief words too.
Great. Good morning, everyone. Steve Carson here. I am a registered nurse by primary education. My focus has been for the last 25 years on population health and quality outcomes management. This topic is really critically important to us as Temple University Health System, because largely the patients that we work with have a deficit of some type related to social determinants of health, whether it's housing, transportation, food. So this type of work and the tools that are available to us are critically important to the success of our patients and being able to manage themselves on an ongoing basis. So excited to be here.
Thank you, Steve. William Morella, Bill Morella is Vice President, Value-Based Care and Analytics at Health Share Exchange. Bill?
Yeah, hi, Brian, thanks. We're here basically to introduce PA Navigate. HSX is one of 4 HIEs around the state that is operating this. So we're doing this under a grant from the Department of Human Services, and just excited to tell everybody more about it.
And finally, I want to introduce Beth McConnell. She is the Director of Policy, Office of Community Empowerment and Opportunity for the City of Philadelphia. Beth, thank you for joining us, and if you want to say a few words as well.
Thanks for having me, Brian, and nice to see you all. So yes, my name is Beth McConnell, Director of Policy at CEO. We go by CEO for short. We're the city's community action agency, and we work to advance stability, mobility, and prosperity for Philadelphians that are living with low incomes. And I oversee our Benephili program that connects people to public benefits, which we think are really critical in advancing social determinants of health and health-related social needs. Thanks for having me.
No, it's great to be here. And I, of course, Brian McDonough, sitting in the, looks like the Marsha Brady position of the Brady Bunch thing. We don't have Andy Davis in here, but we'll all be up here chatting with you. And certainly what I love about this kind of format actually is we can see each other, you can all see, and this will facilitate the conversation back and forth. And if I'm doing my job, I'm saying less and everybody else is saying more. But I do have some questions in the event things slow down. And the first one actually is for Bill Morella, and essentially is to explain further what the PA Navigate program is, how it promotes interoperability between healthcare providers and community-based organizations. How do you see it?
Yeah, sure. Thanks, Brian. So basically, PA Navigate is an online platform to connect Pennsylvania residents to social services. So some of those needs that Steve and some of the others were expressing are all being served by community-based organizations that are listed in PA Navigate. And the website URL, the site's live, you can try this today, but the website URL is pa-navigate.org. And basically this platform is able to address the communication gap that frequently exists between healthcare organizations and their community-based organizations or CBO partners. There are a lot of free workflow tools available to the CBOs, and basically the idea is that sometimes you have to refer someone to a social service several times before they will follow through and take advantage of it. And many of the healthcare organizations we talk to don't always find out whether the patient actually got the service they were seeking, and CBOs don't necessarily have a lot of internal motivation to close those loops unless they are working closely with a healthcare partner or other organization that is sort of a trusted source of those kinds of referrals.
And once again, just to say that it's pa-navigate.org if you want to find out the site, find out more information. And obviously we'll have that information throughout, and the HSX site will have information as well. Let me bring it over to Josh. Josh Claris, I wanted to ask you, we talked a little bit about it, and I was unaware of the impact. It's dramatic of the need for housing and how it impacts our hospitals and care for patients and the cost of care.
Yeah, I mean, I'll address that. Maybe not in exactly as people think of cost traditionally, but really what I think is the true cost, and this is the conversation, right? So where it costs years of life, right? When you think about stress levels that get increased, lack of sleep that gets impacted, issues of hygiene, right? Like all of those things impact quality of life, but actual life outcomes of individuals, and poor housing or lack of housing has significant impact on those types of things. It also costs economic stability and educational, learning outcomes for individuals, right? All of those factors that I discussed, from sleep to stress, but also like your ability to be prepared for work or school the next day, your attention span, attention to details, any of those things that kind of help impact individual and family economic stability and educational outcomes get impacted. So the cost is seriously high when we think about overuse of emergency rooms and lack of housing and other impacts of that.
And it's interesting you bring all that up. We talk about social determinants, and I know during the pandemic it became so clear to me, people we thought we were doing great jobs with, the issues that they faced and how they were vulnerable to COVID. Pandemic, but it really was a reflection of basically their overall health. And you bring up a good point. We asked Steve Carson. I know you are also on the other side, but sometimes too as well, trying to work with community and make things better, and also in a major university hospital setting, seeing these issues.
Great question. Thanks. I want to touch on something Josh said, because I think it's really important for us to look holistically. I can define cost-free. And I will define cost-free, what it looks like from a healthcare system perspective. But the issue that Josh put forward to all of us is really about quality of life and mental life, and those things that really influence us. Only a portion of our genetics really influence our overall length of life. Those things that are, mom and dad, give you when you're born, it only represents a small piece. You have those things such as your housing, the community in which you live in. The difference between the zip code at Temple University Hospital and a center city zip code is 10 additional years of life, just because I live in a different geography. And I think that that's really important to understand. Also those things I may do to myself. I eat too much, I smoke too much, I expose myself to things I shouldn't expose myself to. All those things influence and have a factor on our quality of life. So I think that Josh made a really important point. Now, as I look forward as a hospital administrator, those things from a cost perspective to me are a combination of things. One, that individual being in our emergency room that may not need to be there, but it's the only place they know where to go to seek health care, which is really important to understand. And then oftentimes, when a person doesn't have a place to go, they may need some lightweight ongoing care. And I'll use that word lightweight because you and I, they would send us home and say, go take care of yourself. Some individuals don't have that wherewithal or that place to go to take care of themselves, so they get admitted to the hospital. I use the word social admission. So they begin to take up space as inpatients, they take up space in the emergency room, and it may not be necessary. It may not be the right level of care. I'm not going to use that word. It's not that it isn't necessary. It's not the right level of care that would be traditionally seen in the ambulatory arena. So I think that from a cost perspective, that there is the human cost, as Josh described, but there's also the real socioeconomic cost of inside the hospital and care delivery as well. And I think that there are two factors that as we go through and think about things, you have to think about both, because I think they're really important for how successful someone can be in their health overall.
Bill Maroon, I saw you nodding and agreeing to much of what Steve was saying. Tell me from your perspective why that hit a nerve.
So I just want to share some national data. Is the average American goes to the emergency room probably once every 5 years. But if you are living on the street, you go to the ER 8 times in 6 months. That's average. If you are living in a shelter, you go 4 times every 6 months. Our population is actually even higher than that. We know right now we are working with 3 people who have 60 plus ER visits in the last 12 months. That's more than once a week. We have 8 people who have 20 to 60 ER visits in the last 12 weeks, in the last 12 months. Once we're able to house folks, then we can start talking about food, health, and all those other things. But all those other things are going to be pushed to the side until we're able to house people. But I don't think the general public understands how much housing plays a role in the actual cost and the cost that Josh is talking about.
Beth McConnell, I'm sorry, go ahead. Yes, please.
So if I jump in and tap into Bill for a moment, I wanted to add in, so from a housing stability perspective, just to link on, our experience in one of our programs that we had worked on with a variety of community-based organization, as well as 2 third-party payers, we were able to see emergency room department utilization drop by 67%, just based on the fact that we were able to stabilize that individual's housing and connect them to primary care. I mean, that's really a huge number. And you take those numbers that Bill just gave you and drop them by 67%, that's significant. A, for the individual, because now they're in the system of care where they need to be, but also from organizations being able to take care of individuals who need to be in the emergency room for heart attacks, strokes, and things of that nature. So I think it's a really important point.
Thank you, Steve. It's interesting. I was going to ask Beth this question too as a follow-up that, in your title that we were talking about before, but it's the Office of Community Empowerment and Opportunity. Where would a tool like this help you as you're trying to give people more power in their health and their own care, as well as finding the resources they need?
Yeah, well, I think as Bill Morella pointed out, sometimes we can refer people to resources, but they don't always follow through. And there's usually a reason for that. There's a barrier. There's some sort of barrier that's getting in people's way. Perhaps they don't have access to the internet. Perhaps they have limited English proficiency. Perhaps they're really stressed out because they don't have food in the house, or they don't have a safe place to live, a set of other reasons. So I think where we as providers, right, as healthcare providers, as social service providers, as city government, can really be proactive in being able to connect those residents rather than sitting and waiting for them to come to us. Let's go to them. Let's refer that client from my desk to yours and get them enrolled in SNAP, get them the housing resources they need, get them to a food pantry, whatever it might be. I think that's one way that we can start to stabilize households and stabilize families and improve outcomes for everyone. So what I love about PA Navigate is that ability to make that connection between providers and also see what happens, right? So feels like sometimes we feel like we can send people and it goes out into the void and you have no idea what happens to them. Being able to kind of see the follow-up and see the follow-through is super useful for us to be able to measure our outcomes, measure our performance, and focus on where we need to improve and where we need to target our outreach efforts.
I want to switch over to Bill Morella on this question and taking it a little further with HSX, PA Navigating. In my career, I've certainly taken a considerable amount of time learning about electronic medical records and working with them and trying to use them in clinical settings. But one of the things we've constantly seen as a barrier, as frustration for all of us providing care and even using the tools that we have, is that communication aspect, that follow-up, that working with community-based organizations. And as I learn more about HSX and this project to moderate this panel, it's clear there is a great opportunity here. Tell me a little bit about it.
Yeah, so Brian, I think in a lot of ways, this is an extension of work that HSX has been doing for many years. So, I think most people don't know what a health information exchange does. There's about 80 of us around the country. HSX has been around for over 10 years now, and I think we have almost 400 data sources that are contributing data to us, largely from traditional healthcare environments. What this program allows us to do is to kind of extend that a little further and address more information about sort of these social needs and whether they are being met. I think Pennsylvania is sort of in the vanguard here. There are other states that are doing this as well. But the effort that we're putting into trying to get everybody connected to a single state platform and drive all this traffic through this one website is something that's going to incentivize people to sort of standardize on this platform. A lot of people were already using the vendor that we're working with, Find Help. A lot of people in Pennsylvania were already working with them already. And we're trying to take advantage of that and bring others onto the same platform. And as Beth was talking about, there are tools in the website that allow a community-based organization or somebody who's either making referrals or receiving them to be able to analyze their own activity around the people that they're serving. So that's one way that people can benefit from the system, but it's also available to the general public. So, wouldn't address the need for somebody who, like in Beth's example, maybe doesn't have access to the internet or isn't comfortable using a computer. But for people who are, this is free to the public, and they can self-navigate on their own or for their family or friends.
This is also an opportunity to talk about a wish list and/or barriers that are there. What do the rest of the group see, or Bill as well, do you see as challenges ahead of a project like this? What needs to be achieved? Where should we be heading to get the greatest opportunity in the quickest amount of time to help people?
Yeah, Brian, I'll jump in really quickly for that because I actually think something that Bill just said is really important. And to me, what I wrote down was like this transition to kind of thinking, and I'll play the role of the community here, right, to a certain degree, everybody. And it's like seeing names as data and seeing outcomes as data rather than as people. And I think what is really encouraging about this is it really recognizes social needs, the people in this, and that the outcomes is actually the benefits that it provides to the people. And it either puts the onus or at least shares the onus from the system to the individuals and the families to making sure that whatever health care that needs to be provided is actually, used, right? It doesn't matter if it's given as long if it's not used. And so it is those outcomes on the people that are really important. And so the challenge for this is to make sure that that stays at the forefront, that it's not about the data, it's about the people. It's not about the actual numbers in there. It's about the outcomes that are associated with people's lives and people's well-being. And so that to me is what the potential here is, but it's also the barrier, right? To connect best intentions and the services to the actual kind of people that need the help. And I think that this is a very, particularly, Bill Maroon said that the vulnerabilities of an unhoused population are even more significant and more complicated than people who are either in unstable housing or unaffordable housing or unsafe housing and all those other things. They're at least housed. And so that the levels of complications gets even significantly more. But as long as we use the information, which is ripe which has problems, because in history says that we don't always use that information for the best reasons, but this gives us the potential to really make sure that we keep people at the center of the outcomes we're trying to do.
We talk about people-centered care. It appears to me this is really getting to that level now.
Yeah.
We're not just, a hospital without walls or all those terms. We really are starting to go to the people, which is where the people live, essentially. Anybody have comments about that? Do you see that as, kind of the right time for something like this?
So I just wanted to say, we have 500 people all over the city, and I'm interested in seeing how this will help our staff connect people, because most of our folks live in North Philly, Germantown, West Philly. And I think we probably do a pretty good job in those neighborhoods of knowing the resources. But we have 6 people living in the far Northeast. We have 10 people who live down by the airport. It's going to be really interesting to find out if using this resource help us connect those folks and help us. Maybe there's resources in the neighborhoods we're used to that we don't even know about. But that's what I'm really looking forward to, is making sure we're connecting everybody, no matter what section of the city they live in, to the resources in that community.
So from a Temple perspective, very similar to Bill, we have patients a little bit of everywhere when it comes to where patients reside. We've structured a fairly strong community health worker program who really their focus is specific to social determinants of health. So this tool is a very effective tool in helping them identify resources for our patients, so they're able to connect them to resources. To Josh's point, making sure or assuring that someone will follow up with the resources presented to them. And then our nurse navigators are tied to our community health workers. So they're based on physician practices across the city and the delivery of care around those patients in the practice, and then the referrals to the community health workers, who not only are just tapping into the resources, but they're actually going out and doing the home visits. So they get to see that we're sending food home, but a refrigerator doesn't work. And therefore you have to, replace the refrigerator in order that resource can be utilized effectively. They're the trusted messengers. Honestly, they live in the communities in which they serve, which is really important. So they understand what the needs are, and also understand what people are willing and not willing to do. So I think this tool is an extra additional resource for them to be able to be more effective in their job.
If you're joining us, this is our HSX University session. We're talking about PA Navigate, obviously talking about building bridges in communication between healthcare providers and community-based organizations, and just trying to get this entire, the barricades and blockages, kind of push them aside using technology as a resource to help us. So if you have joined us and you want to enter the chat, feel free to ask your questions. I'll be monitoring the chat. We have people monitoring it, so we could bring up some of your questions if you have specific concerns or issues you want to deal with. I know, Beth, You talked a little bit when we had a chance to talk about Benephili and the work you do. How do you see, because I know you're also trying to reach out to so many different people. Where do you see this helping you, or what do you hope from it?
Yeah, a couple things. One is just to break down some of those barriers. So first, let me just say briefly about the Benephili program. We created it over a decade ago because there are so many barriers to accessing public benefits, and it's a complicated process. There might be 15 different applications with 15 different income guidelines and asset tests and sets of rules. It's really a lot to ask people to navigate, especially when they're dealing with some of the most difficult stuff in their lives, right? Healthcare problems, lack of access to good job opportunities. So the Benephili program, basically we screen residents for a set of like 20 plus benefits that they may be eligible for. And then if they want to apply, we actually walk them through the application and submit it on their behalf. And then our benefit specialists act as advocates to make sure that the paperwork doesn't get lost. If they're unfairly denied, advocating and saying, hey, no, actually they're eligible, make sure that they get enrolled. So that's work we've been doing for the last decade. Last year, we submitted about 6,300 applications for public benefits for Philadelphians. One of the things I'm kind of excited about with PA Navigate, whether there's 2 points, one on data and one on integrating the application process. So I would be super excited if there were a way to more closely integrate, for example, PA Compass, which is the state PA DHS's a benefits application system. So that's where people can go and fill out some online forms, and that will tell them what benefits they're eligible for and directly apply. If we could integrate in some way some of the functions of PA Compass and some of the functions of PA Navigate, we can eliminate some of those other barriers that people are experiencing. So they don't even need a Benephili. We don't want them to need us. We would rather not have to run this program. But as long as people need it, we'll be here. The other thing that I think would be exciting is data. We're all data-driven organizations. We need to also be responsive to where we're seeing changes. For example, we have seen over the last year the number of people that have lost their medical assistance during the Medicaid wind down in the lower Northeast and parts of Northeast grow, like it's a significant number of people on par with neighborhoods like Kensington, where we expect to see those numbers. That's a neighborhood where we don't have the same kind of social service infrastructure like we do, for example, in Kensington, but we see that data there. So could PA Navigate be a source of seeing trends and changes in data and where there are needs so that we as institutions can be responsive to that and build the systems and the support in those places.
It's
Brian,
interesting.
let's interject just to piggyback on that comment. So I know that that's something that the state is also hoping to get out of PA Navigate, is to specifically be able to assess what's the capacity of the social care infrastructure throughout the state, in rural areas and urban areas, and where is it being overmatched by the demand. And when I've talked to people in other states who are rolling out or have rolled out similar programs, several of them have said to me, we rolled this program out, we got everybody using it, it's great, but it uncovered a level of need that was really going under the radar, to Beth's point. And so we are starting to look at that now, specifically with respect to food insecurity and looking where are there low-income individuals throughout the state who may not have access to either a nearby grocery store or a food pantry. Hopefully we'll be able to release that data soon, but that is something that we're able to look at through this platform.
Yeah, I was going to bring up the point of data collection. I know in my clinical career, I mean, many times I've talked about a problem with my patients, and many times I've been told, well, that's a great anecdotal story, but is that reality? Can you prove to me that's reality? And in many cases you can't, because you can't get the numbers. You just know it to be true. In this case, it's kind of a spin-off. I mean, a really nice advantage of having this communication and this tool is that you'll have numbers that you can go back to people and say, yes. Is that why the Department of Human Services kind of, I think, targeted the HIEs? Is that one of the reasons they knew that data collection could be achieved?
Yeah, that's definitely part of it. So, you know, the HIEs have been around for a long time. Everybody who works in healthcare or around healthcare is accustomed to us. We are sort of a trusted source of data exchange. So I think people just kind of saw it as a very natural extension of what we were already doing. The other thing that I think that we'll be able to do down the road, and this is kind of part of the longer term vision, is to actually be able to demonstrate that meeting people's social needs does have the kinds of outcomes that Josh was talking about. You know, someone who's homeless with diabetes is going to be better able to manage their diabetes if they're housed, and we'll be able to show that with the clinical data we already have as we marry that to data around whether the patients are actually engaging with the social care that they're being offered.
All of you in one form or another are working in the community and community-based organizations trying to make differences in your own way. Has what we learned about social determinants, as I say, as a larger population, are we seeing that reflected in any more support for the work you're doing or whatever? I'm just curious. I know people talk about it all the time and it's such a huge issue, but are you seeing that, or is this one of the bright lights, I guess?
For us, it feels like it's never enough. But I along those lines, another thing I don't think the general public understands. We house, again, 500 people. About over 220 of those people have zero income, right? The only thing they might get is food stamps, which is never going to last for the entire month. And that creates such a barrier for everything that we're talking about. Housing's one thing. The next thing is income, right? And, you know, we're in the 24th year of not having welfare as we used to know it. And I think we're experiencing the results of that every day. And it's harder to get people on SSI and Social Security. You know, back in 1979, if you were an alcoholic and a psychiatrist said that was chronic, you got SSI for the rest of your life. We don't that doesn't happen anymore. And so I think that's the next thing that I wish, and I think a lot of other people wish, that this could kind of prove that income supports make a difference and will make a difference for all of us and lower costs for everybody.
Yeah, I'll just reiterate that it feels like, sure, the attention of the spotlight is starting to move, but the problem is bigger than I think that people realize, and the actual and the life expectancy cost is bigger than people have realized, and the long-term effects of policy decisions from years ago is being evident. And so it is a start, and it is important, and there are dollars that are starting to flow, but the percentage of the people that are currently seeing positive results is very small, considering the amount that has to happen.
Yeah,
Sorry, Steve. I was going to say, I think, you know, as many things do, action usually starts local, right? So we've seen a lot of advocacy here in Philly to put way more investment into housing needs. And we've seen more resources go into our housing trust fund. We've seen some healthcare providers put some resources into home repair programs, but it's a drop in the bucket compared to what's needed. And that's why we really need Congress to recognize, as Bill Maroon was saying, that some of these major programs, like our housing programs, need SNAP, others need a way more significant investment in resources at the federal level. We've seen some bipartisan work on social determinants of health related legislation. Hasn't quite gotten none of those pieces have gotten their way all the way through Congress, but we've at least seen some folks coming to the table recognizing those connections and the needs. But really, we need it to go that next step and follow through with those resources.
So going into the future and trying to think of those things, how we do it, what about small groups that may not, they don't have these huge EPIC and Cerner and all these other groups? How does PA Navigate help them if they have a smaller organization? They're not huge, but they still want that communication with others. How will that help? In other words, is there a way to get them into the system through creative uses of technology?
Well, Brian, you're talking about getting individual people access to the
No,
system?
no, more of a community-based organization that may be a smaller organization that, up until now hasn't been linked in to others because they're just so small. But it seems like now there is an opportunity to more or less do it because you've got this tool.
Yeah, and Brian, I'll just interject. So Bill, like for me, right, like in North End, Philadelphia, we're a local nonprofit, medium size, but not connected technically. So, I'm here as a community-based organization. We actually did develop a low-income housing tax credit, apartment building to provide stable, affordable housing for folks. We run a community center with a pantry. But like this, so when I kind of got connected to this, I'm like, this seems great. Like, let's connect North End. So like, let's have a conversation of how that can work between you and me.
See, that's what I'm seeing. I'm seeing people, and again, if there are some people who want to come into the chat who might have otherwise thought in the past, I just have no way of, doing this. But now that there seems like there is an opportunity, because we've seen it on the clinical side. Tons of practices have disparate EMRs, if any EMR or whatever, but they're now able to get involved and use that technology or peek into what the hospital's doing or use an HIE to find out what meds their patients are on, if they've been seen in other hospitals. Like, this seems like it's finally what we've been able to use to kind of cobble our way through healthcare is really possibly going to help with community-based organizations more and more, and some can help others too.
Yeah, and Brian, I think the other thing that I think is going to be helpful in the future is I think this program is going to sort of expand the scope of data sharing in some ways. So it's entirely common, as you said, a doctor can kind of look up in HSX and see someone's medical history if it's someone they've never treated before. That's been true for a long time. But now bringing the community-based organizations sort of into that part of healthcare, I think has a lot of potential. I'm seeing in other parts of the country where some of the social service agencies have actually become business associates in the HIPAA sense with healthcare organizations, so that a healthcare organization that is referring people out, say, to a homeless shelter, if you're referring someone who's maybe an insulin-dependent diabetic, for example, they need to have somewhere to store their medication when they get to the shelter. You've got to be able to communicate that to and make sure you're sending them to somewhere that can handle their medical issues. So that's something that's going on elsewhere in the country. I think we can replicate that here as people get more comfortable, sharing information with community-based organizations that are not traditional healthcare providers.
I have a question for Steve Carson as a Senior Vice President for Population Health at Temple Health. A while ago, I was able to moderate a panel on population health, and one of the decisions was, well, in population health, it also comes down to your population. Is it a prison population? Is it an underserved population? Is it a suburban, whatever it would be? Those populations are all different. Does a tool like this help link these populations together? Like, they were kind of separated by geography or other things, but now it appears to me they don't have to be quite as separated as they once were.
Thanks for that question. So yes, I think the tool does help pull the different groups together. So a really good example of that is just looking at some of the key referral sources that we may have as an organization. Electronically, it may be easier to communicate in that electronic exchange back and forth within that community-based organization based on the type of services that they may offer. So I really see this as a huge opportunity to be able to learn how to do that, what I would call a closed loop referral, as people refer to it. Meaning it comes from us, it goes back to the community-based organization, and they communicate back to us about how that individual is connected to services. So I think that is a really positive aspect. I think one challenge that's out there that we need to pay attention to is that there's lots of community-based organizations out there, and not all of them are able to accommodate the volume they may now see based on the fact that there's resources out there. So I think that we need to be respectful of that and figure out the best way to work with community-based organizations using this tool. And I think that, starting off in a small way that we are at this point, looking at who are some of our key resources, how do they want to work with us, how do they want to work with the tool, is really going to be critically important so they can be able to manage the volume. Because, one of the things that we haven't spoken about while we have this great tool, that community-based organizations have limited resources as well. So now we've taken this huge need and put everybody into this system, and now they're managing this fire hose of referrals. So how do we work with organizations to do that? And I think that that's really important. That's where I think some of the work that the community health workers and social workers help still support that process. So it shouldn't become this tool is the panacea of making a referral. It's just a tool to work with that community-based organization to help start that conversation, to keep track of it. Go back to a really important point people made at the community, to be able to keep track of, how those resources are utilized, consumed, and help us understand what some of the other community-based needs are, so we can collaborate to either help expand them or advocate for them. So I think that that's really important.
Yeah, if I could just piggyback on that. So one of the things that we ask CBOs to do, Brian, is to engage with the platform at least at a basic level. And the simplest thing that they can do is to just what we call claim their listing. So there are 17,000 community-based organization programs listed in the site today, but the vast majority of those have not been claimed by the organization that's listed. So it's just like they're in the phone book. But if there are any CBOs on the line who are thinking about what Steve said about, how do we make sure that we can titrate and don't overwhelm a CBO with referrals that they can't deal with. Engaging with the platform at sort of that basic level of claiming their listing, they can manage their hours of operation. They can flag themselves as not having any additional capacity right now. They can implement screeners that basically, if they have eligibility criteria, like they want to serve veterans or something like that, they can be very explicit about asking the user questions to determine if they're actually eligible for their services, so they're not getting a bunch of referrals that they're not able to handle. So for any CBOs that are on the line, I would just want them to be aware that those functions are out there and can help manage the traffic that they get from referrals to the platform.
We have about 20 minutes on our HSX University, a couple of business points. If there are chat questions, I'm not seeing them, or if you want to add chat questions, at least from the view I have, I don't have any right now, let me know or pop them in. And I'm going to ask this to the entire panel. One of my favorite questions and maybe most important questions, and with 20 minutes to go, it's a good time to ask for you and for the audience, is, are there things we haven't talked about that you wish we brought up? Because, I'm focusing questions and we're doing it, but are there bigger topics, other issues related to this that you think need to be discussed and should be discussed with the time we have? Anybody feel free to speak up.
One thing that also kind of piggybacks on the last conversation we had, which is around language access and cultural competency. So, there are, groups where, for example, it doesn't make sense to refer, certain cultural ethnic groups to a food pantry that doesn't carry the foods that they eat or want to eat or can eat. It doesn't make sense to refer somebody who has a history of incarceration to an organization that does not have the cultural competency to be able to meet their needs and understand the challenges that they faced. So I think as Bill Morello was saying, for organizations to claim their listing and also make sure that they really put out there on that listing what their cultural competencies are, the populations that they really can work with. And then as healthcare providers doing those referrals, thinking about that and looking for those organizations and making sure you're making referrals that make sense. And then to the extent there's an opportunity to build in interpretation and translation and language access into the tool over time, certainly English, but Spanish, and certainly Spanish, but there are lots of other languages too. I think there are some 172 different languages, I think, that are spoken in Philadelphia. That would, I think, go a really long way in helping to bridge some of these gaps and address these barriers.
Thank you, Beth. Other points?
I'm going to jump in on Beth's comments because I think it's really important. It ties into a lot of what organizationally that we focus on, which is really how you ask those questions around social determinants of health. It's really important because as a physician, the physician may ask a question, the nurse who rooms that patient into the office may ask the same question and could potentially get a different answer. And what's really important is the perception of who can really help me, who really cares, and how they ask those questions. We have a pretty standardized tool that we've been using over the last several years. And a lot of the work really comes down to how we train our staff on how to ask those questions, particularly some of the comments that Beth made around the cultural competency, because some people naturally will not answer, yes, I have a problem with food, just from a pride perspective. And therefore, I'm not addressing the needs of that patient. And we as healthcare providers need to understand how we talk to patients, how we listen to patients, so we can be more effective in meeting their needs when it comes to addressing the social determinants. So I think that's really important. And digital competency is really important as well, because oftentimes people say, oh, it's out on the internet. Go out on the internet and find it. And what we have found over time, while many people have phones and can talk, not everybody has a competency to work on the internet and understand where those resources are. This particular resource is hugely based on the internet. So we need to make sure that our patients, as we're working with us, know how to find it, where to find it, how to sign on and get to it. So I think that those things from a competency perspective is really important, not only just culture, but also understanding our patients' internet literacy is really important as well.
And speaking of users and competency, I found many of the people who, I apologize, who have been asking questions. They're under questions, not chat. So let me bring a few of these up for the group. The first is, can you explain who is responsible for facilitating relationships between healthcare providers and CBOs, and how can we ensure partners are actively using the platform for referral processes?
Well, I can take a start at that. So, I mean, I think when I look down the road and I think about, what does success look like? How will I know if, after 5 years, if this program's been successful? One of the metrics that I've been thinking about is an increase in the number of solid relationships between community social service organizations and healthcare organizations. I think both have a responsibility to create those relationships and sustain them. And, like any good relationship, it's got to work for everyone involved in it. So, one of the complaints that the healthcare people have is that the loop is not getting closed on the referral as often as they would like it to be. Where it is happening, though, it's where they have a good relationship with a community-based organization that involves understanding each other's worlds, understanding what each party needs, and also sharing resources to make sure that that can actually happen, and that we're not just asking people to do work with no resources. So I think those are all kind of central to making those relationships work.
This is more of a comment, but I agree with everything being said. We use HSX and have found it extremely helpful in integrating physical health. My hope is that in the future, if psychiatric and substance use inpatient facilities could share the same way the physical health care providers share. That's a wonderful point. There is a need for medical escorts and transportation to medical visits. Many low-income people use the EMS and EPs to be treated, and EDs to be treated for medical issues that can be addressed by a PCP. So I think that's another really good point. I think that kind of goes to what Bill and Josh were talking about. So we have Bill referenced 17,000 CBOs in the system. Is that local to Philadelphia or statewide, since PA Navigate is a statewide program?
That's statewide.
Okay. And addressing the patient in healthcare literacy challenges is also very important, and they're talking about that as well. So I think a lot of the things that we're talking about are being echoed or voiced by others. I thought the substance abuse is a very important point, because I know in my practice, most practices are seeing more and more of these issues as well. This is something that just can't be brushed under the carpet, so to speak. It is a major health issue. Do you see value in improving access to care and care for those dealing with these issues?
Well, I think the answer is obviously yes. So a couple things. I think that, how we are able to provide access is really critically important. There's a wide variety of programming that can be out there. So for example, there's substance use disorder services that can be provided in the primary care practice, Suboxone therapy. That can start with the primary care provider for those people with opioid use disorder who want to engage in management. And there's a wide variety of different programs, not only just from a medical perspective, but also from a housing perspective. I think that is really important because you're seeing a lot of issues out there around different wounds that are out there because of injective and poor injection site management. So I think that you're seeing programs like that. Project Home across the city of Philadelphia and the Stat Lubert gift for substance use disorder really is focusing on bringing together health systems to be able to help manage patients who have substance use disorder, and then really transition them into care into housing if they don't have some type of permanent or supportive housing. So that goes everything from respite all the way through to permanent housing at the end of the day. So that program is really designed to pool resources across the city and be able to look at how people can be placed. We keep on going back to this process step, which says, if I stabilize housing, I can improve the healthcare outcomes of that particular individual. And this particular program, along with programs like Phil has, to be able to really just help stabilize housing, stabilize their healthcare, leads to it. So much of the work that we've done in our early days of housing and understanding what we could do around housing started off with substance use disorder, behavioral health disorders, to be able to help stabilize them as well. So the answer is yes, it is critical that we need to be able to provide that type of support both medically and physically to patients to be successful.
And I just want to jump onto that. So this is for Bill Morella. My dream is that someday we can marry the two informations, right? So this morning I came in and I get an email every day. It tells me every person who went to an emergency room in the city that's with Pathways. So 6 people went in the emergency room yesterday. 10 people went in the emergency room on Saturday. That's what happened over the weekend of our 500 folks. It would be great to have that information, get that information, and this is their address. These are some of the resources in their neighborhood. This person's going to need transport to their follow-up appointment, and these are some of the resources that you can use for transportation in that area. At some point, I believe AI can connect those two things, PA Navigate and HSX information. And I want to just echo the person who put on the chat around getting the behavioral health information into HSX. That is going to be unbelievable data for us to have and be able to react to and be able to connect people to the right resources in their neighborhood.
I don't know what role.
Sorry, go ahead, you go.
I was gonna say, I don't know what role PA Navigate can play in this, but it would be great to at some point see us do more auto enrollment. Like, so if we have the data and we know that somebody is eligible for something, why force them to go through all the steps and have to follow up on the links? Let's just get them the benefit they're enrolled in and deliver it to them automatically. And those are kinds of data sharing agreements that obviously have to happen sometimes between states and local governments and other entities in between. But it would be really great to see more of that. The city of Philadelphia has been experimenting with that, done some pilot programs on auto enrollment on some things. So would love to see more support for that statewide.
Joshua, you were going to make a point.
I think that's a great idea. I wasn't going down that path, but I think that's brilliant. I think that what was on my mind, and that is like the other half of it is like technology isn't like, obviously, like we have to use it, but it's definitely, we're not talking about losing the humanity in all of this, right? And that's what Steve was talking about before with his staff and the people that are out there and the importance of this. And so, but for those people, we have to help them figure out really what their job is along the cultural competency around connecting people and having those long-term conversations and what technology can do and how it can support them. And like, to me, we're using words like relationships, like we want to, like right now, those relationships have to be human being to human beings still. Like, we're not beyond that in any way, as much as the technology can help us, right? AI, yes, and how people can use that, because it's still a person that's got to pick up somebody from where they are and bring them to someplace else. Like that is really important. And the data for the people, like, we need quick wins to these big, long-term systemic social change problems. But if we don't have those like quick wins that data can provide us to understand, then we just feel like we're pushing a boulder up a hill, but it's rolling back on top of us. And that's disheartening and going to continue to push people out of our sector, right? And so that they don't do this work. And I mean, Beth, I'll put it out there to you, like, is Benephilly, like, we use it and we're a partner of yours and it's fabulous until the person doesn't show up. You still need the person to connect one person to the system. And yeah, if there's the auto roll, like, that would eliminate that part of it. But the trust that gets built on those human relationships is just vital. So anyway, I just wanted to kind of like, we're having this as a technology conversation, and my, red lights are going off saying, like, but we need to invest in people too, to the people who are doing this work. And I'm just to reiterate it, the cultural competency of the people who are doing this work is absolutely, like, critical, because the trust between people in the neighborhood, like neighborhoods like Hunting Park and East Tioga that North 10 shares, the trust that those people have in our healthcare system, in the state system, is not where it needs to be in order for them to feel like they will use the system. Like,
Gosh, you bring up a fantastic point, because I've seen it on the clinical side. We've had to change our workflows for many of these EMRs. We've had to do things differently than we ever had, that we figured out as doctors forever. And now all of a sudden we're doing it differently because an engineer built it one way. And that can get in the way of and be a barrier. So I would hope that, and I think it is advanced enough now that the technology is there, that it's the human side that's writing the rules, doing the code, making sure these things are done, and the impact of the community-based organizations, I think, are going to be key. One of the things I enjoyed in talking with HSX as I was prepping for this is the fact they want input, that input's essential, that they can then give input back, to the Department of Health and others, so that PA Navigate becomes something that isn't a barrier, another barrier, but a real tool that helps. So I think your point is very well taken. And I think Beth's point, about language and that being a barrier too. There was another question up here. I can't get to some of the others, but we're talking about literacy and how important that is as well. And I think all of these things are key. We only have it's gone fast, I knew it would, but only about 3-4 minutes left. Everybody want to make final points that they think are critical before we wrap it up?
I'll just add one thing I know we haven't talked about is the 1115 waiver, and it kind of links up with Beth and Josh's comments. So, Josh, what I liked about what you said is, you're making the leap that we need the technology to kind of free people up to do sort of higher order work. So, if we can do auto enrollment, or at least something we've done at HSX is automated screening of people who may be eligible for certain benefits, and then with the right data sharing agreements, as Beth said, sharing that information with organizations that can do that outreach. That may take the workload off of people to let them do things that only people can do. The other thing, I guess, with the 1115 waiver, this is basically a mechanism by which a state gets exceptions to the normal Medicaid rules around what services are reimbursable. And the state submitted an 1115 waiver application to CMS. We don't know yet if that's going to be approved, but that will be bringing funding for social services around 4 key populations: children up to age 6, people with diet-sensitive conditions who may be food insecure, homelessness, and people who are transitioning out of incarceration and going back to the community. So the state is clearly envisioning reimbursing for some of those services. So any CBOs that are operating in those areas or have missions around those populations hopefully are paying attention to that, and should stay tuned.
Anyone else? We have about a minute. If not, Anybody else? Okay, that was actually a good point to wind it up. I want to thank, first of all of you on the panel for giving your time and sharing your expertise. I mean, your passion is clear, and I think that came across. And for those who joined the webinar, I appreciate you giving your time. I respect everybody's time. I know you probably have to get back to the afternoon of work, but I want to thank everybody. Yeah, again, just to let you know, it's pa-navigate.org. If you want to see the site, obviously HSX is there, and you can go and find HSX on the web and learn more as well. But I want to thank everybody for taking your time for joining us and joining HSX University. It was a formative and fun session. Thanks, everybody.
Thanks, Brian. Thanks, everybody.
Bye, everyone.
Great day.
Take care. Bye-bye.